The next speaker I'd like to introduce is Dr. Ron Perrone, and he'll be talking about management of ADPKD in 2024. And welcome, Ron, and I'll ask you to talk from the left side of the panel over there.
All right.
Thank you.
So, York, thank you for inviting me. That's the pointer or the advancer?
That's the
Okay.
advance.
Okay, so these are my disclosures. And these are the goals and objectives of my talk. Can everyone hear me? Okay. So I'm going to review the natural history of ADPKD, including renal and extrarenal complications. I'm going to talk about total kidney volume as a prognostic marker for ADPKD, review management goals, including diet, BMI, blood pressure control, and end-stage kidney disease care, and issues related to CKD 4 and 5. So obviously, there'll be some repetition of themes here. ADPKD is a hereditary systemic disorder marked by bilateral kidney cysts. This is a end-stage kidney shown bisected. About half the people have kidney failure by the sixth decade, and I mentioned extrarenal manifestations. And on top of that, all of the issues associated with chronic kidney disease, which I know you're all very familiar with. So this is a preview of a slide that's going to be published in the 2025 KDIGO ADPKD guideline, just illustrating the long-term course of ADPKD. Kidney volume is increasing over time, and with the increase in kidney volume, the other complications that are associated with ADPKD come along. And I'll talk about lifestyle interventions, including sodium and BMI, blood pressure control, pain management, and Dr. Torres will talk about treatment with tolvaptan. And then obviously, for those who continue to progress, kidney transplantation or chronic dialysis are options that still need to be taken into consideration. So the kidney manifestations of ADPKD are, again, I'm sure very familiar to this audience. Cysts throughout both kidneys, an inexorable increase in total kidney volume due to the growth of cysts, resulting in painful, palpable kidneys, loss of kidney function, hypertension, intermittent hematuria, cyst infection, nephrolithiasis, and impaired concentrating ability. This is I think a classic image from the original results publication of the CRIS Consortium in 2006. And this was a group of individuals, about 241, who were followed in an observational cohort, now for more than 20 years, illustrating the natural history of ADPKD. These individuals, of course, entered clinical trials, received tolvaptan, were in the HALT study, et cetera. But this is the early study before anything was done. And it shows that each individual has their own curve of increasing in total kidney volume over time. Some people increase more slowly and some people increase more quickly, and I'll talk about the factors associated with that. Notably, GFR declined during this 3-year observational study only in those with the very largest total kidney volume. So those with smaller kidney volume, at least at that time, did not have a significant decrease in GFR, and that's very important. This is a slide courtesy of Dr. Bay, and it shows MRI images of polycystic kidneys, illustrating the progressive changes that occur over time. This is not the same individual, but early disease going to later disease. And the T2 weighted images are on your left. And in this case, the cysts are white and the parenchyma is dark. In the T1 weighted images, these individuals, it's just the same persons, same 4 people, but in these studies, gadolinium was administered to increase contrast. We no longer use gadolinium for the purpose of describing cysts and total kidney volume. And in this case, the T1 weighted images, the cysts are dark, and the gadolinium enhanced parenchyma is white. So obviously very easy to see cysts scattered throughout the kidneys. And with advancing disease, more cysts, larger cysts, and increases in total kidney volume. Well, ADPKD is an expensive disease. In the US, if you have kidney failure, you become eligible for a limited form of national health insurance called Medicare. But the direct annual medical costs plus the indirect costs in, this was 2018, resulted in total annual costs of 7.3 billion US dollars. Indirect costs include unemployment and decreases in productivity related to having a chronic disease with pain and potentially limited ability to work. And you can see that most of the costs were associated with end-stage renal disease or kidney failure. But nonetheless, there's significant cost even in earlier stages of the disease. So Terry has talked in great detail about the genetics of ADPKD, and I'm not going to go through this for the sake of time. Again, two principal genetic loci, PKD1 and PKD2. PKD2 is a milder phenotype with later age of diagnosis, later onset of hypertension, smaller kidney volume, fewer kidney cysts, and later age of kidney failure. And as Terry mentioned, there are newly described what we call minor PKD genes. And this is again, a classic slide looking at renal survival, that is survival until time of dialysis or transplant, and illustrating that the median age of kidney failure for PKD1 is about 20 years earlier than the median age of kidney failure for PKD2. So I'm going to show you some more pictures. These are typical ADPKD kidneys. And when we say typical, we mean cysts scattered diffusely throughout the parenchyma, whether it's early disease or later disease. And then there's a whole potpourri of atypical ADPKD kidneys illustrated from Dr. Rosball's work. So unilateral disease, so cysts only largely affecting one kidney, only affecting a segment of the kidney, asymmetric disease, bilateral atypical, et cetera, et cetera. And the importance of this is that the atypical or class 2, Mayo class 2 kidneys have slower progression, and in fact may more likely be associated with the newly described minor ADPKD genes. And again, the atypical diseases are typically more slowly progressive, typically less kidney cystic involvement, variable liver involvement. Some have extensive liver involvement and some have almost no liver involvement. And I've listed the so-called minor ADPKD genes here. And we also now know that monoallelic PKD genes can cause cystic disease. For example, the gene for recessive PKD, when inherited as a heterozygote, can sometimes have liver cysts and kidney cyst manifestations. I'll briefly mention indications for genetic testing in the clinic. I believe there's a consensus that it's not necessary for typical disease with a positive family history. However, there's certain conditions where genetic testing is warranted. So early and severe onset disease, absence of family history, atypical disease, a syndromic presentation that is with other features affecting other organs, evaluation of young potential kidney donors in a PKD family, and for pre-implantation or prenatal genetic diagnosis. There's other scenarios which are potentially research related, where there's marked intrafamilial disease variability and potentially identifying high-risk patients for novel disease modifier therapy. Also coming out in KDIGO 2025 is a revision in nomenclature. So if the mutation is known, we now add that to the name. So someone who has a genetic mutation in PKD1 will now be called ADPKD-PKD1. Same for PKD2, and the same for the minor PKD genes if they happen to be identified. At least at this time, whether the mutation is truncating or non-truncating has not been officially added to the nomenclature, but certainly something that the clinician should be aware of in terms of prognosis. So back to basics. Hematuria is one of the complications of ADPKD. Cyst hemorrhage occurs in about 60% of individuals. There would be microscopic or gross hematuria if the cyst is connected to the collecting system. And if the cyst is not connected to the collecting system, the blood would remain within the cyst or under the capsule of the kidney. And these cyst hemorrhages are thought to be related to excessive angiogenesis over the surface of the cyst. And these blood vessels are fragile and can be ruptured with minor trauma and result in hemorrhage. So patients with recurrent episodes of gross hematuria have the largest kidneys and may progress more quickly to kidney failure. We recommend minimizing trauma in those individuals with large kidneys, but we don't suggest that children and adolescents refrain from sports unless they have very large kidneys with lots of cysts. Pain is a common problem. So we differentiate the types of pain, so acute pain, chronic pain, and musculoskeletal back pain. So acute pain may result from a cyst infection or rupture with or without hemorrhage, torsion of the kidneys, nephrolithiasis, or obstruction. Also consider that some of these same events could happen with a hepatic cyst. Chronic pain is related to cyst expansion, stretching of the capsule, or enlargement of the cystic kidneys or liver, compressing other intra-abdominal structures. And then musculoskeletal back pain refers to the exaggerated lumbar, or comes from the exaggerated lumbar lordosis that occurs due to increased abdominal girth resulting from enlarged cystic kidneys. Urinary tract infection, again, fairly common, more common in women than men. Much of this is lower tract infection. Cyst infection is a serious medical condition. Can produce fever, flank or abdominal pain, malaise, and other constitutional symptoms. And the finding of a positive blood culture in the absence of a positive urine culture is strongly suggestive of cyst infection rather than pyelonephritis. So a cyst infection requires lipophilic antibiotics such as ciprofloxacin, norfloxacin, or trimethoprim for a 4 to 6 week course. Occasionally, you have to drain a cyst if it's refractory to treatment, and sometimes this is difficult. So if you have a cyst with a large, thick wall and pericystic inflammation, that's easy. You know that's the infected cyst. But localization may be difficult, and PET-CT scan may be advised to try and diagnose infection if you're going to drain the cyst. If you're not going to drain the cyst, then there's no need to do advanced imaging like that. So I mentioned quality of life issues. So these large cystic organs adversely impact quality of life, resulting in enlargement of the abdomen, chronic pain and discomfort, concerns about body image. That's one of the more common complaints in the clinic. I go to the gym, I work out, but my abdomen is big, and that can be very distressing. This can result in a sleep disturbance and pain when wearing seat belts. And if you will, this is a collection of images from patients with very large cystic kidneys. And again, you can see the exaggeration of the lumbar lordosis there. So the whole abdomen is thrust forward. This ultrasound criteria for diagnosis of ADPKD in a PKD1 family. This work was seminal work performed by Dr. Pei and his colleagues. So if we know there's a PKD1 mutation in the family, these are using ultrasound. So below age 30, at least 2 cysts in either or both kidneys. Age 30 to 59, 2 cysts per kidney, and age 60, at least 4 cysts per kidney. Well, if you've not done genetic testing, how do you know if it's a PKD1 family? If there's at least one family member, first-degree family member with kidney failure below the age of 55, that is suggestive. It's not proof, but it's certainly suggestive. If you don't know the genotype, but again, there's a family history of ADPKD, the criteria are more stringent. So at least 3 cysts in either or both kidneys from ages 15 to 39. Remember, it was 15 to 30 and 2 cysts. So this is by ultrasound. Again, this is work from Dr. Pei and his colleagues using MRI. Among subjects who are at risk of ADPKD age 16 to 40, you need to have more than 10 renal cysts to be considered. This is proof for diagnosis. And if you're working with a young potential kidney transplant donor, finding a total of less than 5 cysts can be considered sufficient for disease exclusion. And many of these individuals will now get genetic testing in order to figure out the family mutation and whether the donor carries the mutation. So you'll hear a lot about the Mayo imaging classification. This was developed from a group, Dr. Torres, Dr. Rosenbaum, and the CRISP consortium. And what they did was to look at a cross-section of individuals and determine their kidney volume corrected for height at a given age. And they assumed that everyone started at age 15 with a total kidney volume of 150 mLs per meter. And as a result, you can calculate the rate of growth of kidneys. And so from this cross-sectional study, you can see that a young individual with large kidneys, note that this is a log scale, has kidneys that have grown at a much faster rate than this young individual with small kidneys. And prognostically, if you're young and you have large kidneys, just as we saw from that slide from the CRISP study, your prognosis is much worse. And these have been translated into GFR slopes for the different classifications. So again, this is cross-sectional data in which individuals were followed over time to estimate their GFR decline. And this is used as a predictor for prognosis in ADPKD. But it's important to recognize that this only applies to typical ADPKD kidneys, such as I showed you earlier, with cysts scattered diffusely throughout the parenchyma. It does not apply to atypical kidneys, which are called class 2. So when we approach a patient with ADPKD, we start off with kidney cysts, we confirm the diagnosis. If we have a typical ADPKD cyst distribution, we can measure the total kidney volume and establish the Mayo imaging class. And if you're Mayo class 1C, 1D, or 1E, you are considered to have rapidly progressive PKD. And at that point, you could consider whether or not to start tolvaptan, and Dr. Torres will cover this in detail. If you have Mayo class 1A or 1B, you're not considered to have a risk for rapid progression, and you could potentially have your imaging repeated in a few years to see if that's changed. However, everybody with ADPKD should be treated to these general management measures, which I'll talk about in detail, but related to blood pressure control, salt restriction, hydration, maintaining normal weight, and treating hyperlipidemia. Now, this was published in 2018. We've refined this a little bit more, and I'll go into detail. So I have a few cases. This is a 33-year-old female who's newly diagnosed without hypertension, pretty normal estimated GFR. She has a positive family history. Paternal grandfather died at age 39 with hypertension. Obviously, we have incomplete medical information on a lot of the older relatives. Father had kidney failure at age 51, had a preemptive transplant, and we've subsequently learned that the family mutation is a truncating PKD1 mutation. This individual had polyuria and enuresis, also had a sister with ADPKD. And this is her ultrasound. You can see that there are cysts throughout the kidney. An MRI done about the same time, though, is much more revealing, showing multiple cysts scattered throughout the parenchyma. And we calculated her total kidney volume and thought she was a Mayo Class 1B, despite her familial mutation. So I mentioned optimal management. I'm going to go through each of these in detail, and some of the things that have changed since the publication in 2018 is we now recommend a moderate sodium restriction of 2 grams per day, maintenance of normal BMI, control of cholesterol, but blood pressure goals are more stringent than in the past. So the HALT PKD study defined in people with an GFR greater than 60, a blood pressure goal of 110/75 slowed the growth of total kidney volume over a 5-year period. Based on the new KDIGO guideline, we're now recommending less than 120/80, even for individuals with lower GFR, and this is based on the results extrapolated from the SPRINT study. So Terry has gone through this in detail, and I'm sure you'll hear more from Dr. Torres, but if you interbreed PKD rats with rats that don't have vasopressin, you can see that you virtually eliminate the disease. And if you give vasopressin in the form of DDAVP, you make the disease much worse. So clearly vasopressin has a compelling role in PKD. And because of that, question has been asked, well, should I suppress vasopressin by drinking a lot of water? Well, first of all, it's hard to drink enough water to suppress your vasopressin around the clock. And suppressing vasopressin gives you a urine osmolality of below 280. The urine output is also affected by solute intake. So if you eat a lot of salt and protein, you're going to have to drink more water to be able to suppress vasopressin. Of course, you avoid large water drinking in individuals at risk of hyponatremia. And a large clinical trial called Prevent PKD, done in Australia a couple of years ago, did not show a benefit of high water intake, but about half of the participants were not able to meet the goal of suppressing urine osmolality. So even in highly motivated people in a clinical trial getting support from nutritionists, they were not able to lower urine osmolality sufficiently by drinking water. We know from large interventional studies, CRISP, HALT, and DPAC, that salt intake is associated with increased total kidney volume progression and GFR decline. So in the CRISP study, salt intake was associated with TKV increase. In the HALT study, study A showed an increase in both in TKV and eGFR decline, and study B showed, these were individuals with a GFR below 60, showed an increased risk of the composite endpoint of GFR reduction, ESRD, or death. And similarly, in the DPAC study done in the Netherlands, the annual change in eGFR per gram of salt is shown here. So the more salt you eat, the faster your GFR declines. And presumably this is because you're stimulating vasopressin by having more salt in your diet. So Terry has gone through this in great detail. I'll talk a little bit about the clinical aspects, but we know that ADPKD epithelia have abnormal glucose metabolism favoring aerobic glycolysis, which is less efficient, and this is a characteristic of highly proliferative cells such as cancer cells. So how does this translate to people? Well, we know from the HALT study that overweight individuals had faster total kidney volume growth and eGFR decline. And they also, obese individuals had, this is back pain. This is often, usually or always, and you can see that that goes up with weight. And those with no back pain, never or rarely, it goes down as weight is increased. And again, presumably this is related to the effect of the kidneys to distort your posture and pull your body forward. And individuals who lost weight had some improvement in their back pain in the HALT study. There's actually quite compelling preclinical work. So rats and mice with cystic disease showing that mild to moderate caloric restriction, a ketogenic diet, or a beta-hydroxybutyrate supplementation decreases cystogenesis. These are some basic references. And there's been, I would say, an unjustified promotion of this to humans on the internet. And so if you Google ketogenic diet and PKD, you'll find all sorts of stuff. Someone's willing to sell you supplements. But I just wanted to point out, I don't have time to go into it in great detail. There are no controlled studies in humans longer than 3 months in duration. So the question I would ask, first of all, going on a ketogenic diet is not as easy as taking a pill, although some would have you take a beta-hydroxybutyric acid pill, which you can buy on Amazon, by the way, without any difficulty. But there's no controlled studies greater than 3 months. And a ketogenic diet is a lot of work. And there are some safety considerations, including nephrolithiasis, hyperuricemia, hyperlipidemia, and acidosis. So it's not something that should be undertaken casually or without supervision. And we await long-term studies so we know the impact of ketogenic interventions on the rate of GFR decline, on any potential delay in kidney failure. It may be a wonderful thing, but we don't know yet. However, we do have stronger evidence in humans about weight loss. So these are results from a pilot study from the University of Colorado of 28 individuals randomized to dietary caloric restriction, 1773 calories per day, or intermittent fasting down to 532 calories 3 times a week. And this shows the annual change in weight plotted against the annual change in total kidney volume. And you can see that the more weight you lost, the lower your kidney volume was at the end of a year, whereas if you gained weight, your kidney volume was increased. And if you look at it broken down in this way, for those who lost less than 5% versus more than 5% body weight, there was no change on average in total kidney volume in those individuals losing more than 5% of their body weight. And the kidney volume progressed at 5% per year, which is a pretty significant increase in total kidney volume in the range of the Mayo 1D group. Now, this is a pilot study of 28 individuals. However, there's nothing wrong with losing weight to not be overweight. I mean, we all accept that as an appropriate, healthy intervention. And so I think that would be a good thing that you can safely advise patients if they're overweight or obese. What we do with normal weight individuals is not entirely known. So this very nice paper illustrates what we think are the appropriate areas to target. I'm just going to focus on the weight. So for BMI greater than 25, consider weight loss, consider caloric restriction under medical guidance, and caution in children and young adults. Children are growing, so it's implementing diets in children is more challenging. For those individuals who are non-obese, maintain weight, maintain a healthy lifestyle. So there's a lot of material on the internet about time-restricted feeding and intermittent fasting and all that. None of these are proven in ADPKD, and none of them are necessarily better than any other way to lose weight. And so from this article, there's insufficient clinical/human data support the following interventions, including ketogenic diet or beta-hydroxybutyric acid. It talks about the risks that I've mentioned, and a long list of supplements here of which there's no data in humans or no benefit in small short-term studies. Your patients will read about things on the internet. They'll be seduced by what seems like a no-brainer, but I think we really need to be careful and do studies. This is another case, a woman with 45 years old with more advanced disease, has hypertension. Her GFR is 61, unknown family history, and the main symptom, fatigue. She's Mayo 1C, again, typical distribution of cysts throughout the kidneys. We know that the renin-aldosterone-angiotensin system is activated in ADPKD, and we think this is related to cysts compressing vessels, resulting in a model akin to bilateral renal artery stenosis. And that results in increased renin and angiotensin II, resulting in increased aldosterone, renal sodium retention, and increased vascular resistance, resulting in hypertension, and angiotensin II also having impacts on fibrosis and mitogenesis. So the HALT study demonstrated that intensive blood pressure control that is less than 110/75 based on home blood pressure measurements resulted in a 14% slower rate of total kidney volume growth over 5 years, reduced LVMI, reduced urinary albumin excretion, and reduced renal vascular resistance. And there was a borderline impact on eGFR progression. There was no benefit of combined ACE-ARB. And study B had a treatment goal of 130/85. There was no benefit of combined ACE and ARB. Listed the preferred order of treatment. We certainly would recommend starting out with ACE or ARB and leaving dihydropyridine, calcium channel blockers, and diuretics for later treatment if you need to add on second and third drugs, and also using a cardioselective beta blocker. This is an individual who had a lot of pain due to cyst hemorrhage. This is a CAT scan with contrast, and you can see the cyst hemorrhage over there. This individual had a unilateral nephrectomy that was done while his GFR was 38. And, you know, the concern, of course, if you're taking out a kidney and someone who's not on dialysis or not transplanted, you're going to push them on dialysis or transplanted. But it was thought to be worth the relief of pain in this individual. And then, so I'm down to 2 minutes, York. I guess I can keep going a little. Okay. So this is an individual, a 41-year-old female who had disabling left upper quadrant stamping pain and abdominal bloating. This is her enlarged polycystic liver, and she ended up having a PKD2 mutation. Her family was somewhat disrupted, but we did find ultimately that her daughter had liver cysts and her mother had kidney cysts. So we think that there was a, if you will, a typical family history. So hepatic and pancreatic cysts are found commonly, up to 80%, asymptomatic in many patients, but can expand and cause pain, abdominal distension, and infection, typically worse in females, and occasionally you end up with really massive PLD, which can be disabling and very difficult to treat. We generally would recommend avoiding exogenous estrogens, and that raises questions about oral contraceptives and postmenopausal hormone replacement therapy. So if a young woman had evidence of significant liver cyst disease, you would not want her to be taking estrogen-based contraception, and you might even want to avoid low estrogen or even progesterone-only contraception and use barrier means. And so cardiac valvular abnormalities are noted: mitral, tricuspid or aortic valve prolapse and regurgitation, dilated cardiomyopathy. Seminal vesicle cysts are common in men. They're not thought to impact fertility, but they're there. And occasionally a man with PKD shows up in a fertility clinic and these are found, but they're not thought to cause obstruction, although that would be a concern. This is a massive polycystic liver that's being partially resected at Mayo Clinic. And you could see if you had that in your hands, it would be hard to tell that from a polycystic kidney. I'll briefly mention brain aneurysms, obviously one of the most feared complications, but fortunately relatively uncommon in ADPKD. So the risk of rupture depends on size and location. We know that smoking, uncontrolled hypertension, and alcohol use increase the rupture rate. Found in approximately 5% of patients with no family history, and about a quarter of those or less who do have a family history of intracranial aneurysm or subarachnoid hemorrhage. So we typically screen those with a positive family history, so-called high-risk occupations. So you would want to screen your airline pilots, but you would probably want to screen anyone who is worried about having an aneurysm, and we generally are fairly liberal about going to offer it to anyone who is concerned about that. Management should be done with a multidisciplinary team, including neurointerventionists, neurologists, neurosurgeons, to make sure you're getting the best advice. So optimal management in CKD4, so you're kind of heading toward kidney transplant or dialysis. I think the most important thing is to prepare for kidney replacement therapy, manage complications, and the preferred modality for ESKD would be a preemptive live donor transplant and appropriate preparation, anticipation of such. Seeking out a living donor is not a simple task. Many people volunteer to donate and they either don't show up or they don't pass the medical evaluation for a variety of reasons. So it's very important to start that process early. Very briefly, we know that survival after end-stage kidney disease is better than the general end-stage kidney disease population. We know that peritoneal dialysis is successful in ADPKD. Issues relate to hernias, large kidneys and liver, and diverticulitis. There's no objective data on the success of peritoneal dialysis as far as total kidney and liver volume is concerned. And that's a research need that we need to figure that out. Regarding hemodialysis, there is a risk of cyst bleeds from anticoagulation. We know that the mortality from extrarenal issues is far less than that due to cardiovascular disease, and the transplant outcomes of people with PKD is similar to other patient groups. So last few slides, indications for pre-transplant nephrectomy. So I know most of the patients I speak to with PKD would not want to have their cystic kidneys there once they're transplanted. The issue is the timing of that and whether or not you really need to do it. So to remove a kidney or both kidneys before transplant means you're going to put someone on dialysis. So you have to have a good reason. So recurrent or severe infection, symptomatic nephrolithiasis, recurrent and or severe bleeding, intractable pain, a suspicion of renal cancer, and then space restrictions, taking into account that kidney size typically declines after transplantation. And again, there's no objective data about kidney size and does a transplant fit in the extraperitoneal space. And for that reason, if the surgeon really thinks the kidneys are too big, the surgeon should only take out the one on the side of the transplant. I'm going to go through this quickly. The other options are simultaneous nephrectomy or deferred or staged nephrectomy. And each of these has advantages and disadvantages. But certainly for the simultaneous kidney transplant and nephrectomy, you need a very experienced surgical team to do this. And we know that kidney volume decreases over 1 year after transplantation. So with that in mind, one can safely defer nephrectomy. So there's a lot of supportive data to support blood pressure, dietary, and lifestyle interventions to improve kidney and cardiovascular outcomes. We have a method to establish the risk of rapid progression. There's one approved agent, and there are others in the pipeline. Thank you. Do we want to do this? Okay, so we have a quiz. Dietary sodium intake should reduce to, and I believe you have your QR codes, to reduce the rate of total kidney volume enlargement, decrease likelihood of nephrolithiasis, improve blood pressure control, lessen the fluid requirement to maintain reduced urine osmolality, or E, all of the above. And I'll leave it to the technical staff here to.
I already mentioned it in the beginning. So
Yeah, you have a QR code and there's a tab on the Zoom to go to the quiz. All right. Well, is that one? Oh, 9 responses. So the answer is E, all of the above. All of the things I mentioned are important with regards to dietary sodium. Okay. And let's go to the next slide. Okay. So optimized ADPKD management should be initiated when the GFR is less than 60, only when the blood pressure is found to be elevated. In all patients, when Mayo imaging classification suggests increase of progressions, that is 1C, 1D, and 1E, and when family history demonstrates end-stage kidney disease below the age of 55. So we can go to your responses. So the correct answer is in all patients, even those who are at risk of slow progression, nonetheless will benefit from these important lifestyle interventions.
thank you very much, Ron. I think there's a question for you.
Okay.
Considering the increasing popularity of the class, is there any role for SGLT2 inhibitors in polycystic kidney disease?
So that's an excellent question. The package insert or the label for SGLT2 inhibitors indicates that there's no data in people with PKD, and that's because people with PKD were excluded from those trials. So the official position of the KDIGO group on this is that you should not use these agents in individuals with ADPKD until there's further evidence in humans. And the concern is in clinical studies, there's worse, preclinical studies, there's worse cystic disease, and it's thought that the osmotic diuresis associated with SGLT2 inhibitors stimulates vasopressin, which can make the cystic disease worse. If the indication would be for an ADPKD patient with heart failure, it's thought to be justified in those individuals. Yeah, I mean, you could ask the same question about the non-steroidal mineralocorticoid receptor antagonists and also the GLP-1 receptor agonists. Although I did see a poster at ASN showing a benefit in preclinical models using the GLP-1 RAAS. There's no evidence of harm, though, so I think you have to make the decision with the patient, informing them of that information.
Thank you very much, Ron.